So antenatal care is systematic supervision of a woman during pregnancy. Now it has the aims of antenatal care are: the aim is to screen high risk cases to prevent or detect any complication, either prevent or detect complication at an earliest, send them to proper referral systems, then to educate them about childbirth, and to come up to devise the proper plan about mode and place of delivery, and after delivery about family planning services, and taking them to these mother and baby classes like mothercraft classes where they demonstrate how to take care of children and about the benefits of breastfeeding, etc. And yeah, so basically these are the aims. Objectives are to assess that health, to make sure that mother and fetus both have the best health. So you keep assessing health of the mother and fetus, you check the gestational age, and carry out all the underlying investigations that are needed, and you organize continued obstetric care and risk assessment. So what are the objectives? We have three basic objectives. That is, first we want to assess the health status of mother and fetus, then we want to check the gestational age and carry out proper investigations based on it, and next we want to organize these continued obstetric care and risk assessment. So what are the different components of antenatal care? First is in each antenatal visit, firstly you have to register her. So this registration card is made on which name of the mother, her husband, like basic history is taken. So registration is the most important thing. And she should have frequent ANC visits, wherein in each visit history is taken, then examination is done, then antenatal health care, immunization, routine investigations, then risk-based approach is carried out, then health measures and mental preparation, advice, family planning, and pediatric components. So these are all different components of ANC care. So first, when the woman comes to us, we take basic history. This is like any obstetric history, wherein we just ask for name, age, or occupation, address, husband's name, then what is her obstetric score. In one line we have to ask that. So obstetric score has different components. You have gravida and paragravida is how many times the woman has conceived, or pregnant, or the number of pregnancies. Basically this can be past or present, any number of pregnancies, whereas para is number of previous pregnancies that have reached the that have crossed the period of viability. So through the GT PAL system we have to grade, we write the obstetric score. After that we come to the complaints. So complaints like if she has any vomiting or increased risk of micturition, etc. So we go about that, and then we take history of present illness. Then we go for obstetric history. In obstetric history we also ask about the past histories. In obstetric history first comes the past pregnancy if she's a multigravida, but you ask about the mode of delivery, how's the what kind of conception, if it was a booked case or not, any complications during pregnancy, during labor, during puerperium. Then next we go for history of present pregnancy, where we take history trimester wise. In first trimester there increase history of nausea, vomiting, and micturition. In second trimester quickening is felt, and about immunization. Third trimester per vaginal bleeding, leak, and symptoms of impending eclampsia. So this is at the history level. On examination, every time we go for general physical examination, where we assess for pallor and we check her weight gain, then uterine height is checked, abdominal circumference. So this abdominal circumference and uterine height is also called as gravidogram, and it is used when facility of USG is not available. You compare it with a fixed standard chart with the standard values, and you evaluate whether the fetus is growing properly or not. USG is generally preferred and is available everywhere these days, so that practice has been abandoned, but yeah, it's pretty much still done. And on examination we basically check for jaundice, we check for oral hygiene or neck, for thyroid enlargement, because as we know during pregnancy size of thyroid increases, and we check for edema in pregnancy, her pulse rate. Then we go for obstetric examination. In obstetric examination we have per abdominal, per vaginal examination. So she has to always empty her bladder before per vaginal examination. First we inspect, then speculum examination, bimanual examination. Now coming to edema in pregnancy. So edema is basically swelling which is evident. Edema is basically fluid which is present in the extracellular compartment, and edema can be in different degrees. So edema, if it is present, usually it's present in the legs in pregnancy. Now in pregnancy there can be two types of edema, physiological and pathological. Physiological is because there is increase in the volume of blood, so there is hemodilution. but along with that albumin is decreased. So as a result of decrease in albumin because of decreased colloidal oncotic pressure, there is basically transfusion, like the blood goes into the fluid, basically moves into the extracellular space, leading to edema. This is what is happening in physiological edema. Now this physiological edema is because there is compression of the gravity, and another point that leads to physiological edema of pregnancy is that the gravid uterus compresses on the inferior vena cava, and it is leading to increased pressure in the veins. So that is another reason why there is edema, and this edema can be it's mainly seen like at the end of the day, and it is relieved by rest. It's fitting type, and it is always slight degree. It's more towards the right side because on the right there is more compression over the veins, and it is not associated with any features of preeclampsia, eclampsia. It disappears on rest, and other pathologies are all absent. But edema can be pathological also, so that is seen in obviously heart diseases, in preeclampsia, in anemia, hypoproteinemia, nephrotic syndrome. So here in preeclampsia, what kind of edema will we have? We have edema wherein firstly they'll come with features of raised BP, and like they have increased blood pressure. Along with that, they'll have a headache, epigastric pain, low platelet count, etc. So they come with symptoms of PIH. Along with this, edema here is very peculiar. So normally edema, physiological edema of pregnancy was reducing on rest, but pathological edema reduces on walking. So that's a very peculiar point. Then if we talk about cardiac failure will be associated with ascites and murmurs. Similarly, nephrotic syndrome is associated mainly with periorbital edema. Then there can be triglyceridemia, a little bit of hematuria, and anemia because of again it can lead to cardiac failure. So these are the different causes. Edema can vary. The grades of edema can vary. It can be pitting or non-pitting type. Usually all these features are of pitting type. And alright, so we can write pathogenesis about how decrease in colloidal oncotic pressure, increase in hydrostatic pressure is what is responsible for transudation of fluid across the membranes and into the extracellular compartment. Now grade 1 is when it is still the ankle, grade 2 is the knee, and grade 3 is like anasarca, the whole body is involved. So management for physiological edema, nothing, just take rest, elevate limbs, try to lie in left lateral position, and it should subside. For pathological conditions, you give their respective treatment. Now coming to the routine investigations which are done during pregnancy. So when we talk about routine investigations, first we begin with blood. In blood we go for blood count. So in pregnancy, the RBC count, hemoglobin is less. So even though this is mainly happening, even though like HP, hemoglobin, like RBC volume, RBC mass basically is increasing, but that's increasing only by 20%, whereas plasma volume is increasing by 80%. So as a result of that, there is fall in the hemoglobin level. Then platelet count and WBC count. WBC count might be slightly raised. So we check for this. We go for peripheral smear to see if there are any hemoglobinopathies or any disorders that can be there. Then we check for blood glucose level, VDRL, serology. For torch infections mainly, this is done. HIV testing is done. Then on urine, we check for proteinuria. Asymptomatic bacterial culture is done. Urine culture is done. Then we check blood pressure. Blood pressure is checked once at the first antenatal visit, and then after that 24 weeks. Then we also, and for urine examination, we take midstream clean cat sample is collected, and cervical cytology is done, so pap smear is done. Then special investigations include ultrasonography. So we explain about different types of ultrasonography. Then aneuploidy screening, where we check for alpha fetoprotein, estriol, and HCG levels. And we check serological tests for rubella, same thing, torch infections. And you have to repeat these investigations, mainly hemoglobin, at 28 weeks. Urine testing is for protein and sugar is again repeated at all the antenatal visits. So this is what happens. Now we know that we need at least so the number of ANC visits also, yeah, so we need to know this. So ideally in the first 7 months, each month one visit. Next in the 8th month, every 15 days one visit, and in the last month every week one visit is allotted. So but according to WHO 4 visits are enough. So when are these 4 visits to be done? That is somewhere around 16 weeks, 24 to 28 weeks, 32 weeks and 36 weeks. So this is important. Next we have different components. Like we have to talk about antenatal diet. So we should ask her to have a good diet, eat good balanced food. And now this is a 5 marker actually. So the diet during pregnancy has to be adequate, and then these dietary recommendations are just a background. They're just telling us on what kind of, it's basically more of an advice. There's no strict stringent diet plan that they're supposed to eat so and so only. They can have anything, but basically try to